Welcome to the Wilderness Medicine elective lecture on traveler's diarrhea. My name is Maura Carroll and I am a resident at the Mount Sinai Hospital's Department of Emergency Medicine. Our objectives for this lecture are to define traveler's diarrhea. We're going to talk about who's at risk for severe infections. You will learn the diagnostic and treatment options and when to apply them. And then finally, we'll talk about some prevention strategies. Digging a little bit more into what we'll talk about today, we'll start with some basic definition. What is traveler's diarrhea? Move into some epidemiology. We'll talk about an approach to a patient, because that's why you're here, to learn how to treat these patients. Diagnosis, treatment, and prevention again. So why are we worried about diarrhea? Diarrhea is a leading cause of morbidity and mortality worldwide. According to the CDC, 1 out of every 9 deaths in children worldwide is due to diarrhea. Oftentimes, these patients are in resource-poor countries. As ED providers in the United States, we're going to see diarrhea present often as traveler's diarrhea, so patients who have recently traveled or come from endemic areas, which we will talk about as well. To start off, let's talk about what traveler's diarrhea is defined as. Traveler's diarrhea is defined as 3 or more unformed stools in 24 hours. Typically, you need one of the following symptoms to go along with that: abdominal cramps, fever, fecal urgency, which means you feel like you got to go all the time, tenesmus, bloody mucoid stools, nausea, and vomiting. We can further define traveler's diarrhea into a category ranging from mild to severe, and then a persistent category as well. Mild traveler's diarrhea is defined as diarrhea that is tolerable, it's not distressing, it's not interfering with planned activities. It might be a little bit uncomfortable, but otherwise you're able to continue on with your vacation, your job. You're able to do your activities of daily life normally. Moderate traveler's diarrhea is defined as diarrhea that's distressing or does interfere with your planned activities. So that means you might miss a tour on your vacation, you might not be able to go into work that day, but you're bothered by it. Severe diarrhea is incapacitating or completely prevents all planned activities, and we typically categorize it in grossly bloody stools, known as dysentery. Technically, that falls into the severe category. Persistent diarrhea is diarrhea that lasts greater than 2 weeks. So this map, adapted from the WHO, shows the endemic areas for traveler's diarrhea. This map also includes where cholera, one specific bacterial type of infection, is also endemic. So if you take a look, it's a huge majority of the world has some sort of endemic pathogen for traveler's diarrhea. And oftentimes these fall into areas where people are often vacationing and returning back to the United States. Overall, the risk of traveler's diarrhea is 10 to 40%. So now that we know where traveler's diarrhea is endemic, let's talk a little bit about what causes traveler's diarrhea. So several different types of pathogens can cause traveler's diarrhea. The most implicated is a bacterial infection. Viruses can also cause traveler's diarrhea. And then finally, the more rare cause, but will be seen from time to time, is parasites. To dive in a little bit deeper, here are those 3 categories again, with some of the main implicated bacteria, viruses, protozoa, and parasites that often cause traveler's diarrhea. Take a minute to read through these lists. Bacteria is the most common cause of traveler's diarrhea, and namely the enterotoxigenic E. coli, ETEC, for short, ETEC, is the most common cause overall of traveler's diarrhea. 20% are caused by bacteria Shigella and Campylobacter. Salmonella constitutes 4 to 5%. Other bacteria, Vibrio, Aeromonas, Plesiomonas, and then the rest, viruses and parasites, make up the other 10% of traveler's diarrhea. Bacterial traveler's diarrhea pathologically falls into one of two categories. Typically, it's either a secretory diarrhea or it's an invasive type diarrhea. The majority of traveler's diarrhea is secretory diarrhea. What that means is the toxins or bacteria cause an osmotic gradient. Fluid flows into the stool, which leads to diarrhea and looser stool. This typically affects the small bowel. It's watery. There's typically no blood and no leukocytes in the stool. High volume, and we describe it as low toxicity, meaning otherwise the patients usually look well as long as they're staying hydrated. Causes, main one we just talked about is ETEC, E. coli. Most of the other bacteria cause a secretory diarrhea, viral, and then a parasite, Giardia, also can cause secretory. Invasive diarrhea is the more toxic appearing diarrhea. It's pretty uncommon. What happens in this diarrhea is bacteria itself invades into the intestinal mucosa directly. Typically, this affects the colon. We also typically see dysentery with that. What that means is there's blood in the stool. Oftentimes, there's leukocytes as well. Low volume diarrhea, meaning you're not going to have a ton of episodes of diarrhea, and the patient appears more toxic. So that could constitute just a general ill appearance in addition to vital signs changes. The causes of invasive traveler's diarrhea are Shigella, Campylobacter, Salmonella, Entamoeba histolytica, and Vibrio parahemolyticus. So now let's talk a little bit about how a patient would get traveler's diarrhea. So there's several main transmission modalities for these bacteria, viruses, and parasites. The far and away the most common is a fecal-oral transmission, and that has to do with lack of hygiene surrounding bathroom visits, and then to eating, shaking hands, being out, doing normal daily activities. Secondly, food and water contamination can also cause an exposure to a pathogen that could cause traveler's diarrhea. And specifically, hepatitis A, which can cause diarrhea, is a sexually transmitted infection as well. But far and away, the most common cause of transmission is fecal-oral transmission. So let's talk a little bit about what to do when you see a patient who is endorsing diarrhea. So in general, our approach as ED doctors is always kind of figure out as quickly as you can, is this person sick or not sick? That's not to say they're not having symptoms, but you want to know, is this a more toxic appearing patient? Or are you focused more on symptom management? So ways to do that is you always want to check a set of vital signs. Fevers, tachycardia can be signs that the patients might be more ill than they might look. And then, of course, you want to go on general appearance. Oftentimes, patients who are extremely dehydrated, ill, they don't look that good. And the more patients you see, the more comfortable you'll be saying, I don't feel like this is a particularly well patient. This is toxic or not. Secondly, you want to get a good history. As with any patient, you want to know what is their past medical history. So you want to also think about, is there any reason for the patient, missing a T on this slide, to be at increased risk? And we'll talk a little bit more about who those patients are in just a moment. We want to know when the symptoms started and how long they've been going on. And we'll talk about treatment a little bit later, but this will actually change your management depending on how long these symptoms have lasted. All right. You also want to ask, what kind of symptoms are they having? Maybe they're just having loose stools without any of those other symptoms that go along with the definition of traveler's diarrhea. Maybe they're having a different type of symptom set that might make you think of something else entirely. And then you finally want to figure out, has the patient taken any treatments or been treated before for their symptoms they're presenting to you with. After your history, you want to do a good physical exam. So again, we're going to go back to the general appearance. You certainly want to check mucous membranes and examine the belly. In general, you want to do a full, thorough physical exam. Those are the main parts we want to make sure are okay in a patient presenting with diarrhea. In general, testing is not typically required with traveler's diarrhea. The following list is a list of different tests, laboratory tests that can be performed. We'll talk about when to utilize them, but just to describe what these tests do. One is a stool culture. So what this typically tests for is it examines if there's Shigella, Salmonella, invasive E. coli, and Campylobacter within the stool itself. You can request other bacteria. This top bullet point lists several different types of bacteria that you can request to add on. Unfortunately, stool cultures cannot identify viral agents, and they actually cannot tell you what type of E. coli that you're dealing with. So you might have a positive E. coli test without really knowing, is this a pathologic type of E. coli? And then if there's bloody stool, fever, culture can sometimes identify Campylobacter, and as we mentioned, Shigella. Stool leukocytes are also used to help differentiate what type of traveler's diarrhea a patient is infected with. If there's recent antibiotic use, you would consider getting a Clostridium difficile culture, which can change your management as well. Finally, there's an ova and parasites stool study that will identify Giardia, Entamoeba histolytica, and Cryptosporidium. Typically, these are only ordered on patients who have persistent symptoms beyond 10 to 14 days. That could signify that maybe it's not a typical bacterial viral infection, that they might need further treatment for a parasite. Typically, they have upper GI type symptoms, which are described as bloating, nausea, and gas. If it's even persistent beyond that, some GI doctors will perform a sigmoidoscopy, and then they'll do some further studying that typically is not utilized in a traveler's diarrhea patient. So that brings us to the question, who should be tested? So these are the indications for ordering those types of tests and considering other diagnostic options in patients. The first is severe illness. So if you have profuse watery diarrhea with signs of hypovolemia, meaning they're not looking well, you might consider. If there's passage of greater than 6 unformed stools per 24 hours, if the patient's having severe abdominal pain that's not relieved, and if they need hospitalization, it can help you kind of identify and confirm your diagnoses. Other signs or symptoms could be concerning for an inflammatory type diarrhea. Those would be bloody diarrhea, passage of many small volume stools containing blood and mucus, and if they have a fever, so temperature over 38.5 degrees centigrade. Similarly, you want to consider testing in high-risk host features. So to go back to our history taking, this is when your past medical history comes into play. So you want to be a little bit more concerned and cautious for patients who have an age greater than 70 years old. If they have comorbidities in past medical history, such as cardiac disease, which may be exacerbated by hypovolemia or rapid infusion of fluids. If they have any type of immunocompromising condition, including HIV infection. Inflammatory bowel disease, it puts you at risk for higher risk infections as well. So consider testing those patients. And then finally, pregnancy. Those patients typically have decreased stomach acidity and decreased GI transit time, and so they might need a little bit more support to get through a traveler's diarrhea infection. Also consider testing in patients whose symptoms persist for more than 1 week. And then anytime there's a public health concern, if there's diarrheal illness in food handlers, healthcare workers, and individuals who are exposed to many people, including daycare centers. I also wanted to take a minute to bring us back to the pediatric patient. We started off this lecture talking about how the morbidity and mortality, especially amongst children in the world who have traveler's diarrhea. So even though we typically don't live in the endemic areas in North America, we do want to take special consideration of our pediatric patients. They are at higher risk of dehydration and severe illness. So what you can recommend if parents are concerned, they should be seeking out medical care if there are any signs of dehydration, if there's any signs of bloody diarrhea, or if they have a persistent temperature around 102 degrees Fahrenheit, that's 39 degrees Celsius. If there's also persistent vomiting. So another thing you can recommend to parents of pediatric patients is to keep a close eye on their urinary output. In children who can't tell you how they're feeling, oftentimes that's a good indicator of how hydrated they are staying. Has the patient been traveling in Thailand? No, let's say no, they were not. And then we need to ask another question. Is there dysentery? Is there blood in the stool? If the answer to that is no, you want to consider a fluoroquinolone for 1 to 3 days or rifaximin for 3 days. So there you go. You can try that. If you follow up with your patient, they fail to respond to that treatment, then you can use azithromycin for 3 days. Azithromycin is a treatment considered ideal for drug-resistant bacteria. So in effect, if they fail our first-line treatment, we go to our second. All right, so let's go back to our traveling in Thailand question and take the other branch down. If your answer is yes, you're done. Azithromycin, okay, for 1 to 3 days. You are empirically treating as if they have a resistant Campylobacter, and it will also cover the other bacterial type infections. All right, so let's go down our last pathway. So let's say they had not been traveling in Thailand, so our answer is no. We ask the question, dysentery, is there blood in the stool? And the answer is yes. Then we're a little bit worried about a more severe infection, so we're going to go ahead and skip our first line and go to our second. So we're going to go ahead and treat with fluoroquinolone for 3 days. So we're going to treat with the fluoroquinolone. If it fails to respond, then we go to our second line. Okay? So antibiotic options for moderate and severe only. So we've ruled out mild cases already. These are the different types of options that we can use for those patients. Ciprofloxacin, 500 milligrams BID for 3 days is our first line treatment. Rifaximin, 200 milligrams TID times 3 days is also considered a first line treatment. Then we want to move on to our second line. This will cover resistant type bacteria. Azithromycin, 500 milligrams daily for 1 to 3 days, or you can give a 1 gram in a single dose. Consider these in patients who are children, who are pregnant women, travelers from Southeast Asia with possible quinolone-resistant Campylobacter. As for symptomatic treatment, so bismuth subsalicylate, Pepto-Bismol, can be used for treatment in the time of acute infection. It can also be used in prophylaxis. We'll talk about that in a minute. And then you want to consider loperamide, which is Imodium, basically slows down the motility of the GI tract and should decrease large volume diarrhea. And then Lomotil is another type of anti-motility agent that will slow down transit time. Can be considered as well. So let's talk a minute about Pepto-Bismol. Most of you are probably familiar with this, but it can actually be used in 2 different ways with traveler's diarrhea. So as I mentioned, you can actually take this as a prophylactic medication. So the dose for that would be 2 tablets, which is 263 milligrams per tablet. You take 4 times a day. It actually has great evidence that it does prevent traveler's diarrhea, and they note the rate to be 40 to 60% prevention rate if you're taking prophylactic Pepto-Bismol. If you already have symptoms and you have a diagnosis of traveler's diarrhea, then you're taking it for symptomatic treatment. The dose for that is going to be 525 milligrams. That's going to be every half hour for 8 doses. Side effects could be constipation, nausea, and important to note, black stool and tongue. Oftentimes these can get confused with melanotic type stool, which is concerning for a GI bleed. So be sure to counsel your patients that they will have those changes in the stool. It also can produce a black tongue. There is a risk of toxicity with an overdose. There is salicylate in Pepto-Bismol, so be sure to counsel patients on adhering to the correct regimen. Contraindications to this would be an aspirin allergy. And then be cautious when prescribing this in patients who have renal insufficiency, gout, or an anticoagulation or aspirin use, and our children. So say you go through your algorithm, you give your patients first or even second-line antibiotics in addition to some medication for symptomatic control, and it doesn't work. So then that's when you need to consider that it could be a parasite. So maybe you're giving medications that aren't doing anything at all for what is actually causing your infection. If that fails, you don't even really need to test, but you could get those oviparasite stool studies, but you could even just give empiric metronidazole, 250 to 500 milligrams 3 times a day for 7 days, or you could even give 4 grams as a single dose. Tinidazole is another medication that you could use, 2 grams as a single dose, and you can repeat again in 1 to 3 days. So one of our most concerning features that can present with traveler's diarrhea is dehydration. In fact, that is typically the cause of morbidity and mortality, especially in pediatric patients who suffer from infectious diarrhea. So here is the recommendations for oral rehydration salts from the WHO. To the right, you'll see a photograph of a oral rehydration salt pouch. So basically, you take this, it's already prepared electrolyte solution and glucose solution, and dissolve it into 1 liter. And then above the directions that say dissolve into 1 liter, it says that each packet contains the equivalent of, and it goes through sodium chloride, potassium chloride, trisodium citrate, and glucose anhydrous. And that will give you a sense of what electrolytes and glucose are being repleted. This table over here, again, repeats those ingredients, and then about the grams per liter that is ideal for rehydration. If you don't have those fancy packets, there are ways to make equivalent fluids to oral rehydration. Here are a couple recipes, you could say, for oral rehydration solutions. You can take 8 ounces of fruit juice, and you can add half a teaspoon of honey or corn syrup, and then 1 pinch of salt. You can alternate with 8 ounces of water and 1/4 teaspoon of baking soda. Similarly, you can take 1 liter of water, add 1 level teaspoon of salt, and 8 level teaspoons of sugar. You can also consider other choices like rice water, coconut milk, and diluted fruit juice. So finally, I'm going to get closer to the end of the lecture. We'll talk a little bit about prophylaxis. So we've talked about how to diagnose and to treat traveler's diarrhea, but how do we even prevent this from starting? And who needs prophylaxis? It's such a common illness, and most people have mild disease. Per the CDC guidelines that have been updated in 2017, antimicrobial prophylaxis should not be used routinely in travelers. So it's a very strong recommendation. It does say low level of evidence, but they're saying it is not important to routinely prophylax these patients. Antimicrobial prophylaxis should be considered for travelers at high risk of health-related complications of traveler's diarrhea. So think back to those past medical problems we discussed. Those are the patients that are higher risk, and then you want to start considering prophylaxis in those patients. Bismuth subsalicylate may be considered for any traveler to prevent traveler's diarrhea. It is not an antibiotic, so it will not contribute to antibiotic resistance. And this might be a little bit safer if you do want to prescribe something as a prophylactic agent. When antibiotic prophylaxis is indicated, rifaximin is recommended. Fluoroquinolones are not recommended for prophylaxis of traveler's diarrhea. And so moving forward, just consider, if you want to prophylax your patients, consider their risk factors. Consider bismuth subsalicylate as well. And then one final word on prevention: disinfect your water. So make sure you're drinking clean water. Wash your hands, so that will break the fecal to oral contamination and encourage others to do the same. And then finally, you want to eat cooked foods, so you're not being exposed via the food you're eating. And the famous phrase is boil it, cook it, peel it, or forget it if you are traveling in an endemic area with traveler's diarrhea. So here is a good example of foods on the left side that are recommended, foods to be cautious of or to avoid on the right side, as by the CDC. And that wraps up our lecture on traveler's diarrhea. Go out there and diagnose and treat.